Anyway, so today's webinar is going to be all about helping pregnant women stop smoking. And I'm going to talk you through some of the intricacies around the health effects of smoking in pregnancy, but more importantly around nicotine, given that the use of nicotine replacement therapy is something you do every day in pregnant women who smoke. So if we just start off by recapping on some of the health effects of smoking during pregnancy. And as you all know, there are some short-term outcomes and some long-term outcomes you may or may not.
Most people have got their mute on, and I think that's what he asked for.
Oh, okay.
Just to mute it.
So if we start with the short-term health risks, you probably know of things such as small birth weight babies, premature birth, and you might also know that there's an increased risk of sudden unexplained death in infancy, or SUDI, which used to be called SIDS, or sudden infant death syndrome. Smoking during pregnancy, though, also alters brain structure and function in newborns, and this is where we think that some of the risks of developmental problems might stem from. What you may not know is that smoking in pregnancy is associated with some long-term health effects in the infant and then into adulthood, including an increased risk of overweight and obesity. So if you smoke during pregnancy, then your child is more likely to grow into an overweight or obese adult, more likely to experience high blood pressure later in life, and then all of these respiratory illnesses like increased risk of wheezing, asthma, and just airway overreactivity. So just more likely to experience some of those asthma-like symptoms. There's also links to smoking in pregnancy and diabetes later in life, which may be partly tied into the risk of overweight and obesity. So I don't think you need to explain all of these health risks to every single pregnant woman who smokes, but you might need to deal with some of the misconceptions that women might have. For example, a lower birth weight baby means a birth. I know sometimes you hear people say, but I know someone that smoked throughout pregnancy, or I smoked throughout pregnancy last time and had a big baby. Don't forget there are other causes of having high birth weight baby. For example, if you're an obese woman or overweight and obese, then you're more likely to have gestational diabetes. And gestational diabetes is, of course, a risk factor for a large baby. Large babies typically grow into obese babies, which grow into obese adults. So I think perhaps the better way to talk about this is talk about healthy babies. That's what we all want, is to have these kids reaching their full potential. And there are a whole lot of factors, of course, to consider. One of the key risks of smoking during pregnancy is the risk of sudden unexplained death in infancy, or SUDI. Now, this Venn diagram here comes from the report of the Surgeon General. So they talk about SIDS, or sudden infant death syndrome, in the US. And you can see here that smoking is just one of many factors. So smoking is an important risk factor for SUDI, but not the only one. And you can see on the right-hand side of the screen, some of the problems associated with sleeping. So face covers, overbumping, bed sharing are all risk factors in that as well. Now, carbon monoxide. I think this is something we forget about a little bit when we're talking to pregnant women. And this is something I think that is important, because you can measure this. And this particular paper here, published in 2004, so it's a little bit old now, but they made the point that carbon monoxide is the most biologically significant reproductive toxin in cigarette smoke. So don't forget to talk about this when you're talking to your pregnant women. In fact, I'd stay away from the nicotine issue and focus more on this. I think that will give you a little bit more buy-in, perhaps, especially given that they can blow into your monitor and see that. Now, when you're thinking about carbon monoxide, it's got a number of adverse effects. It affects the placenta. It, of course, decreases oxygen carrying capacity to both the mother, but also to the fetus. So, of course, the developing baby relies on oxygen from its mother, and if mum's carrying carbon monoxide, the fetus is also exposed to high levels of carbon monoxide as well. And on your carbon monoxide monitors, you can look at percentage carboxyhemoglobin, which is the proportion of all your hemoglobin on your red blood cells, which is responsible for carrying oxygen, that's bound up with carbon monoxide. Carbon monoxide also adversely affects brain development in the fetus. So it's not just responsible for decreasing your oxygen carrying capacity, it's a potent fetal neurotoxin as well. So that means that it essentially damages the nerve growth. And again, when you're talking to pregnant women about the effects of smoking, remember they're due to a number of factors. It's not just nicotine, it's not just the carbon monoxide. There are a range of other toxins in tobacco smoke as well. Now, of course, it would be ideal for any pregnant woman to be both nicotine-free and tobacco-free. And I guess that's the goal that we're all trying to aim for. But of course, the people that we see in our stop smoking services are, of course, those women that are just struggling to stop smoking, so struggling to become tobacco-free, let alone nicotine-free. So this is why we use nicotine replacement therapy in pregnant women. Now, in terms of interventions, as you all know, for everyone, you get your best effects when you combine pharmacotherapy, that's stop smoking medicines, with counselling or with behavioural support. Now, these data are from the Cochrane Review, which was updated this year. So this is looking at psychosocial intervention, so counselling, financial incentives, health education, social support interventions. Now, there are two things here on the screen that are effective for helping pregnant women stop smoking. Multi-session behavioural support, or I've just turned this counselling on the screen here, and that can increase quit rates at delivery by around 40%. So you can see here this risk ratio of 1.44. It's increasing long-term quit rates compared to control, which is often very minimal support, by about 40%. If you look at financial incentives, the increase in quit rates is even greater, so 2.36. So it's more than doubling quit rates if you're using financial incentives. So again, here's another good bit of evidence from the Cochrane Review, showing that financial incentives are a good way to help pregnant women stop smoking. Looking at things that didn't have any evidence of effectiveness, counselling provided as just one component of a broader intervention didn't work. So this would be if your midwives are just providing a bit of counselling on stopping smoking as part of everything else they're trying to do, then that doesn't have an effect. Now, that shouldn't be surprising to you, because you know that these women are typically very highly dependent smokers, and so a one-off counselling session is unlikely to have any effect. Talking to people about the health risks of smoking in pregnancy and the benefits of quitting, that doesn't do it either. And again, these women are highly dependent smokers, and many know at least some of the health risks of smoking. So there's no point in just talking about health risks. And interestingly, the interventions that looked at increasing social support, they were ineffective as well. Now, it's a bit unclear why this would be. The studies are relatively few, but when you're talking about these social support interventions, that would be focusing on whānau, maybe partners of pregnant women who smoke, providing their support. I think it comes back to the fact that if you're going to provide the best model of care, then it needs to be multifactorial. It needs to include multi-session behavioural support. It should include carbon monoxide monitoring. You should be perhaps incorporating financial incentives now, that the evidence, I think, is pretty strong. Now, some of you may have heard about the Counties Manukau smoking cessation intervention using financial incentives. And Michelle Lee and I did an audit of our data earlier this year. And I'll just talk you through some of this, because I think you'll find it quite interesting in how financial incentives might work. Now, the audit took people that were referred to the service prior to the offering of financial incentives. So that's, you can see the cursor on the screen here. There were 219 women referred prior to financial incentives. And this was just over 19 months, so about 1.5 years. And then after financial incentives were implemented, we had just over, or nearly 1,200 pregnant women referred over a period of 47 months, or that's close to 4 years. So what we found is that financial incentives really made a big difference in the number of referrals that we were receiving. And I think really here you're seeing the fact that people are coming because there's an incentive involved, obviously. But it also significantly increased the proportion of women that went on to set a quit date. You can see here, before financial incentives were offered, 33% of women set a quit date, and this increased to 49% of women setting a quit date after the incentives were put in place. Now, that was a significant increase, but of course you might think, well, gosh, only half setting a quit date, that's still quite low. So yeah, there's still work to be done there. In terms of ethnicity, what we saw is a significant increase in the proportion of Maori women that were attending the Stop Smoking service, almost a 10% increase there. And we also saw an increase in the proportion of younger women that were attending. And again, that was a significant increase. So we're tackling the priority groups here. Did it make any difference to quit rates? Well, at 4 weeks, there wasn't a lot in it. You can see here 4 weeks self-reported quit rates, 62% prior to incentives, 68% after. If you look at CO validated quit rates, CO validation wasn't routinely done 4 years ago. So here in the incentives phase, we're up to around 10%.
Yeah. Yes, turn. Yeah.
In the 12-week self-reported quit rates, though, there was a significant.
Yeah, that's why.
Can I just ask everyone to mute their lines again, please?
No.
Now, in terms of pharmacological interventions, as you know, NRT is really the only medicine that we can use in pregnancy. Currently, both Zyban and Champix are not recommended for use in pregnancy. There are some data on the use of these medicines in pregnant women, but they're mostly in women that were using these medicines before they knew they were pregnant. Now, in terms of the increase in quit rates, or the evidence of effectiveness for nicotine replacement therapy versus placebo, the Cochrane review, which was updated a couple of years ago, shows a benefit of NRT. Now, it's pretty close to the margin here, but you're seeing around about a 40% increase in quit rates at delivery. So I think this gives us some confidence, or it should do, in using NRT in pregnancy. But don't forget, it's the behavioural support that really counts here as well. In terms of safety, there are no differences between NRT and placebo groups in terms of rates of miscarriage, stillbirth, premature birth, birth weight. You can see the list there. So that's looking fairly good. One study, I'll show you the study in a minute, compared the NRT group to placebo group infants at age 2. So they followed these infants up until they were age 2 to look at what happened over the time. And what they found is that those women that used NRT pregnancies had higher rates of survival without any developmental impairment than those that used placebo. So again, some positive news here that we're not seeing NRT adversely affect development of the infants. Of course, these are just small studies, and I would expect that any adverse effect of NRT is probably going to be pretty small. I'll just show you a couple of trials that have been completed. Now, these are big studies using NRT in pregnancy. One's called the SNAP trial, the other one was SNP. SNAP trial was conducted in the UK. Over 1,000 women who smoked at least 5 cigarettes per day. They were pregnant, obviously. And they were randomized to receive 16-hour patch or placebo. Now, in this study, the midwives provided a mix of telephone and face-to-face support. The NRT was provided in 4-week supplies. And the primary outcome was validated abstinence between the quit date and delivery. And this was the study that measured birth and outcomes as well. So they were looking at any disability or behavioural or developmental problems assessed at age 2. Now, in terms of quit rates, here they go here at 1 month after the quit date and at delivery. Now, if you look at 1 month, you can see this big difference here in the quit rates. So those that used the active patch were significantly more likely to quit than those that used placebo. And you can see here almost a doubling. But at delivery, that had slipped off a little bit. Now, probably this was due to poor adherence to treatment. It's quite difficult to get pregnant women to carry out taking NRT long term. And so that's probably what you should focus on in particular when you're helping pregnant women stop smoking, is to keep on using it for as long until they feel safe that they're not going to relapse to smoking. This slide's showing you the infant outcomes at 2 years. And this is the proportion surviving with no impairment whatsoever. And what you see here is that if you're a woman that got nicotine patch in pregnancy, you are more likely to have your infant survive with no impairment than those that got placebo patch. And that's simply because if you got the nicotine patch, you are more likely to stop smoking. So this is just reflecting that stopping smoking in pregnancy, the earlier you can stop, the better. And that's not only good for the pregnancy, but also good for the infant past, into that 2-year period. Now, this is a SNP trial. It was undertaken in France. It was a relatively small study, only 400 women, and they were also randomized to receive the 16-hour patch or placebo. The difference in this study, though, is that their patch dose was adjusted to their saliva cotinine levels. So in this study, the women provided salivary cotinine, or saliva sample, which they measured cotinine in. For those of you who can't remember what cotinine is, cotinine's the main metabolite or byproduct of nicotine. So nicotine's broken down to cotinine. So it's a good indication of how much you smoke. So women got their patch dose aligned to their baseline cotinine level. So the higher they smoked, the greater the patch dose they got. So the patch doses range between 10 and 30 milligrams per day. Remember, the standard patch dose for the 16-hour patch was 15 milligrams. Then they were assessed monthly. They had their patch dose adjusted as needed, and they had behavioural support. And again, the primary outcome in this study was validated abstinence between quit date and delivery. Now, you might think that actually tailoring your dose to your baseline nicotine consumption would be a good thing, but in this study, they found no difference in abstinence rates at all. A slight difference, but it wasn't significantly different. And actually, overall, the quit rates were really low. You can see here, if you remember back to the SNAP trial, it was closer to 20%. Here, we're looking at between 5 and 6%. So really, really low quit rates here. And in terms of birth outcomes, they measured birth weight, head circumference, preterm birth, and transfer to the neonatal intensive care unit, and there were no significant differences between those two groups. So again, sort of safety-wise, this is looking okay. In terms of patch dosing in pregnant women, you might know, and I'll discuss this in a minute, that pregnant women metabolize nicotine a little bit more quickly, and so perhaps the higher the dose, you might expect to get a better result. But maybe a combination of patch and gum would be a better outcome. Just to share a story with you, I inherited a pregnant woman, postpartum, who was on 5 full-strength patches a day and still smoking. And she was told, just to keep up increasing the dose of patches until she stopped smoking, which she'd been doing but hadn't managed to quit. Now, I think this should just be a note to everyone that sometimes it's not all about the nicotine dose. Sometimes it's about the speed of nicotine delivery that's important. Now, I ended up stopping all her patches and switching her to 4 milligram chewing gum, and that's what she's using, around about 20 pieces of gum a day, but she's now not smoking. So, think about these things carefully. Don't just keep loading people up with patches thinking that you're going to get to a level where no one's going to want to smoke anymore. Don't forget to consider some of the other aspects of smoking that people might find important. This is the speed of delivery that's important, or the behavioral aspect of smoking. So now I just want to finish up with notes, some notes around nicotine use in pregnancy. Now, remember, mums who smoke are getting their nicotine from cigarette smoke. And this is very rapidly absorbed. So, puff by puff, they're getting big hits of nicotine to their brain very quickly. Now, the nicotine moves from the maternal circulation, from mum's circulation to fetal circulation really quickly as well, within about 15 to 30 minutes. So, as mum's blood nicotine levels rise, so do babies. Now, I mentioned before that pregnant women metabolize nicotine faster. So nicotine's cleared more quickly, and the half-life of cotinine is also much, much shorter. So this means that pregnant women are breaking down nicotine faster. And this is why we think pregnant women might benefit from a slightly increased dose. It's difficult to know which women will or not, because we're not typically measuring these things in pregnant women. Carbon monoxide doesn't show you this, but just keep this in mind. Now, I'm sorry, my artistic skills aren't very good here, but I've tried to sketch out here. Here's the placenta. So this is where the fetus gets the nutrients from mum's blood. So you've got mum's blood coming close to baby's blood here, and this is where most of the nicotine comes through to the baby. Now, the baby mostly gets rid of nicotine and carbon monoxide, for that matter, back via the placenta through mum. So when mum's blood nicotine levels are high, the nicotine flows from mum to baby. To go the other way, baby has to wait till mum's nicotine levels drop low again. So this is why it's important to have some nicotine-free time. Okay, so it gives baby a chance for the blood nicotine levels to drop. Just so you know, though, that this is the placental sac, or the amniochorionic membrane. Now, nicotine does come across this membrane as well. Okay, so you will get nicotine coming from the blood vessels, mum's blood vessels, coming across the amniochorionic membrane, and it accumulates in the amniotic fluid. Now, baby also swallows amniotic fluid, so you've got a bit of recycling of nicotine going on here as well. Okay, so it's not just all through the placenta. Now, I guess the most worrying part of nicotine per se, so taking aside all the other factors associated with smoking, is the effect of nicotine on brain development. Now, neurotransmitters act as growth factors for neural development when baby's growing. Okay, so acetylcholine, for example, is a neurotransmitter, and that tells neurons, nerve cells in the brain when to stop or start growing. Now, nicotine, as you all know, looks like one of these neurotransmitters. It looks like acetylcholine to the brain. It acts on these nicotinic acetylcholine receptors, and so it too can tell these neurons when to grow or stop growing. And so the thing that we worry about is that stimulation of these receptors at the wrong time halts normal nerve growth. And if you're doing that, you can reduce the number of nerve cells in parts of the brain. Now, this is mostly theoretical, mostly from animal studies. So we're not exactly sure that this is how it happens in humans, but this is the theory. Now, what does that mean in reality? Well, this is the mechanism by which we might see changes in behavioral development or learning difficulties. This is the mechanism that it might increase the risk of sudden unexplained death in infancy. And it also seems to be a dose-response relationship. That is, the more nicotine you have, then the higher the risk. Okay? But again, this is theoretical. So it's a whole lot of different factors here, and the adverse effects of nicotine are probably influenced by the dose, the rate, and also the route of delivery. But don't forget that in people who smoke, they're getting lots of nicotine very quickly delivered with a whole lot of the other toxins that you get in tobacco smoke. In terms of NRT, it can't be said to be safe. So I think you've got to be careful when you're talking to pregnant women about this is 100% safe. It is safer than smoking. Okay, so that's the thing you should be talking about here. NRT is safer than smoking. There may be some risk, but any risk is much, much less than smoking, given that NRT provides a smaller dose, typically slower delivery, and it's not absorbed into the arterial system. So you don't get those big peaks that you get with smoking. And just as an example here, these are some data from a number of different studies, which shows you blood nicotine concentration with smoking. So you can see here 24 micrograms per litre, with the 21 milligram patch 14, 2 milligram gum 6, and 4 milligram gum, very similar to the 21 milligram patch here. Okay, so all less than smoking and delivered in a slightly different way. So when you're weighing up the risks, these are some of the things that you should just keep in mind. It's the risks of smoking during pregnancy are far greater than the risk of exposure to pure nicotine. You can't say NRT is completely without risk, but on balance, the use of NRT to aid smoking cessation is entirely reasonable. Now, NRT and breastfeeding, nicotine is present in breast milk. Now, remember, breastfeeding is incredibly important for a whole host of reasons. Breastfeeding is important to reduce the risk of childhood obesity, for example. And even if a woman is smoking, you should encourage them to breastfeed. Nicotine does accumulate in breast milk, but the infant receives quite a small amount of nicotine compared to an adult using NRT. And that's because the infant drinks the breast milk and a lot of the nicotine is not absorbed in that way. So the dose of nicotine the infant's getting through this route is unlikely to be hazardous. What's more hazardous is environmental tobacco smoke or secondhand smoke. So, encourage family to stop smoking is the best way to go here. So just to finish on some recommendations, and these are aligned with the New Zealand guidelines. NRT can be used, but it should be used in combination with behavioural support. Use the lowest dose of nicotine effective for achieving cessation. Now, you won't know what that is to start off with, but you should take an approach where you start low and you build up. Now, oral products might be better for this because people can use more or less depending on how they're feeling. Now, I know a lot of women can't tolerate the oral products in pregnancy because of that, especially early on because of the taste. But if they can't tolerate them, then use a patch. Okay. But if you're going to use a patch, take it off before going to bed. And finally, initiate treatment as early as possible. So you should aim to get in there, help women stop as soon as you possibly can. If they can get off nicotine replacement therapy and tobacco, that's great. But if they're at risk of relapsing to smoking, then keep them on the nicotine replacement therapy for as long as it takes.